Excellent. Well, we'll make a start. So I'm delighted to be chairing this session and to introduce you to Warren Larkin. Warren is founder of Warren Larkin Associates in 2017, and he's spent 24 years in the NHS specialising in mental health, psychosis and trauma. He worked as an assistant on long-stay psychiatric wards, developing as a clinical psychologist in Manchester, focusing on CBT and family interventions for psychosis, later leading on a national centre of excellence in the first episode treatment of psychosis, influencing service improvements and policy. He went on to work within the public health sector and as a visiting professor at the University of Sunderland, where he researches the effects of childhood adversity, publishing extensively. So I'm really delighted that he's here to talk to us. Over to you, Warren.
Thank you. Can you hear me all right? Fabulous. I'm no longer a visiting professor at the University of Sunderland, just recently, just for clarity. But anyway, I was for a very long time. Lovely to meet you all. Thank you for coming. So I'm going to talk about trauma and resilience-informed practice. You might have heard of this term, this term called trauma-informed practice. It's kind of become a bit of a buzzword. I kind of love it and I hate it at the same time, but we'll get into why that is. So, declaration of interest. I run a consultancy called Warren Larkin Associates, inventively titled, named after me, and I work with a bunch of associates and we work in the field of trauma and we improve outcomes for staff and service users by applying trauma and resilience science to improve things for people, which is pretty much what I've spent my whole career doing. So I spent 30 years working in the NHS, specialising in trauma. Well, actually, no, I specialised in psychosis, which inadvertently meant that I specialised in trauma, because everybody I ever met with psychosis had experienced trauma. So it's kind of an indirect route to specialising in trauma for 30 years. I developed a programme, the other declarations, I developed a programme called REACH, Routine Inquiry about Adversity in Childhood, where we train professionals to how to ask about adversity in a sensitive and helpful way. Okay, so we've got to start with stress. So this whole thing that we call trauma, or traumatic stress, or PTSD, or however we conceptualise it, is really about this subject of stress. Traumatic stress is obviously a harmful form of stress. Trauma means injury or wound, and we're talking about a kind of injury or wound inflicted by stress, harmful stress. So the concept of stress really before the 50s was applied to engineering. It was not really a word that was associated with humans and well-being until Hans Selye borrowed it from engineering. It was the kind of effects of force acting against resistance. And Selye is kind of the godfather of stress research. He was an endocrinologist, and he was nominated for the Nobel Prize 17 times, but never won it, which I think is hilarious. Well, it probably wasn't to him, but, you know. So actually, he created this kind of understanding that we have today in terms of stress. And he described it as a biopsychosocial phenomenon. He talked in his book about the general adaptation syndrome, which really describes the body's response to stress, to external stresses. We've become quite focused and quite preoccupied with traumatic stress. And I describe that as stress that's injurious or toxic or harmful. And it happens when the demands made on an organism, or a human in our case, exceed its capacity to cope with it. So that's when things start to get damaging and people stop coping. There was another theory in mental health called stress vulnerability, which is kind of similar, that once we get to a point where we're under so much stress, we become vulnerable and we stop coping. So this is the best 3 sentences about trauma that I've ever read, I think. And I added the balancing scales at the bottom, the apothecary scales. I did that because that's my metaphor. So traumatization, this harm that happens when people are exposed to overwhelming stress, only occurs when our internal and external resources are inadequate to cope with the external threat. So what Bessel van der Kolk's trying to say here is there's a set of scales going on, really. And if we've got on one side of our scales stress, trauma, tragedy, loss, adversity, the slings and arrows of outrageous fortune, and on the other side of the scales we've got social support, people that love us, coping strategies, assets, ways of adapting, things that we've learned to keep us healthy. So if there's a good balance, we remain in this place called health, or homeostasis, as Selye coined the term. But if we get too much stuff landing on this side, so too much of this harmful stress, and it builds up, the scales tip and we become unwell. And that imbalance could be physical health problems, it could be mental health issues, it could be social problems, but we stop coping. So there's a solution, there's a number of solutions, and I think there are two main ways that we restore balance. One is by removing some of the pain of this burden here, and we can do that through psychological therapies. We can take away some of the pain, some of the distress. We can process some of those memories and events. We can contextualize some of those memories. We can change people's beliefs about themselves, the world, and other people. That's kind of what psychological therapies do. They're really effective. I probably delivered trauma-focused CBT and CBT for psychosis, EMDR, to hundreds, if not thousands of people. So the results could be miraculous. I've also had it myself. I've also received trauma-focused therapy myself. So I can attest to the fact that it is incredibly powerful. But the problem is, most people can't access those things. Or if they can, it's going to take them a couple of years, by which things get worse. So that is a problem we've got to address. But this is a brilliant way of redressing the balance. Lots of people don't get access to this. So instead we focus on this side. And we help them build their resilience, their coping, their social support. And probably the single strongest bit of evidence around recovery from trauma is social support. So relationships are the best medicine. It predicts recovery. People who don't have good social support tend not to get better. People who've got really good social support tend to do better than people without. So this is, if you take nothing away from today, from my talk anyway, this metaphor, this set of balancing scales is where it's at. We can acquire resilience assets. We can acquire ways of coping. We can learn different ways of recovering and building our well-being. So we've got to work on both sides, is what I'm saying. Traumatic events are really, really common. So most people experience something traumatic that would fit with a psychiatric manual's definition of traumatic. This was a study funded by the World Health Organization, and they looked at 26 countries, 69,000 people, filled in surveys, 29 questions on that survey reflecting DSM at the time. 70% of people on average said they'd had at least one potentially traumatic life event at some point when they completed the survey. And 30% of people had 4 or more traumatic life events that fit with DSM at the time. So these are like most people. What we also know is that most people recover without any help. So 70% of people will recover after a single event without any treatment. 20 to 30% of people won't recover at all without treatment. And up to 5 months, people can recover naturally without any help. After 5 months, the graph goes through the floor. So after about 5 months, if people haven't recovered, they need some professional help. The other thing this study showed us was that cumulative trauma also is a problem. So the more trauma you're exposed to, the greater the risk that it's going to affect your well-being in some way. And they also confirmed that social support was the most protective factor. So people who were married did better, they recovered. Some rolling of eyes in the audience I can see, but social support's really important. What else do we know? Adverse childhood experiences. So trauma that happens in childhood, developmental trauma, because our brains are growing, our bodies are growing, our bodily systems are developing. This is why it can have such a long-lasting impact on health and well-being. Because if you think about that period, that crucial period of child development, many of these events can derail that. They can change the way we feel about ourselves, the world, and other people. They can change our social and emotional development and trajectory. So actually, these things have been studied extensively over the last 25 years. This list not exhaustive, of course. There are lots of other things that affect people's health and well-being that are toxic in terms of the impact of the stress that they're going through. But this is the list that's the 10 ACEs, the 10 adverse child experiences that have been most studied. The original study on the right-hand side was Felitti and Ander in 1998. And they discovered by accident that when you survey a population, in this case 9,500 people in California, you found out that in the population, in the general population, there's an incredible exposure to childhood abuse, childhood neglect, childhood loss, violence at home, parents with addictions, parents with mental health issues, which was shocking for them. And at the time, 25 years ago, they couldn't get a slot on a conference like this to present their findings because nobody wanted to know. But it's only in the last few years, I'd say last 5 years, that this science, this adverse child experiences science, is becoming visible in policy and practice. So it's very interesting that that took so long to become visible and palatable. I think now, because we can't meet demand and we've run out of money, I think people are starting to realise that if we can address some of this stuff, we can move upstream a little bit, we might be able to have better outcomes. But what the key thing from that study was it found a dose-response relationship. So the bigger the exposure in that population to childhood trauma, to that list of 10 things, the worse people's health was. So they found that people exposed to more adversity had worse physical health, worse mental health, and worse social outcomes. And that pattern, that dose-response pattern between childhood trauma and health outcomes, social outcomes and mental health outcomes, has been stable over the last 25 years. There have been about 50 population-based studies across different countries over time, using similar methodologies, some retrospective, some prospective. But the evidence base is really strong. These patterns are really stable. So we know that the more childhood trauma you're exposed to, the worse your health's likely to be, the worse your mental health's likely to be, and the worse your social outcomes are likely to be. It's irrefutable at this point. So it's very strange that we still don't ask people about childhood trauma as a routine part of our assessment. So if our assessment is about working out what are the things that contribute to the problem and working out some solutions, our assessment absolutely must contain questions about childhood trauma. If not, then we're not doing a thorough assessment, are we? So these things are rarely asked about. It was policy in the Department of Health on the care programme approach for people with mental health issues. Care programme approach said every 12 months you should ask people, one of the standard questions, mandatory question was, have you experienced physical, sexual or emotional abuse any time in your life? We did a Freedom of Information study to 56 mental health trusts, and none of them had ever done an audit on whether professionals were asking these questions. So it's not a palatable question. People don't want to ask it, which is why I'll talk more about the training and the kind of confidence building work that is important later on. But what we know is people with more ACEs have worse physical health, more chronic illness, more heart disease, more cancer, more diabetes, more often involved in violence, use more emergency services, use more frequent appointments at GPs, do worse in education, more likely to be involved in, to go to prison and use drugs and become addicted. So pretty much everything you can measure over the last 25 years has been proportionately and positively associated with exposure to childhood trauma. Here are just some examples. So the one on the top left, is it top left from where you are, yeah? This was the original ACE study, 9,500 people in San Diego, California. People with 4 ACEs compared to those who had none were 5 times more likely to use illicit drugs, 7 times more likely to self-identify as being addicted to alcohol, and obviously most people lie, so that's probably quite a good statistic. When your GP asks you how much you drink, of course no one tells the truth, I'm sure. So these people were pretty confident that they were addicted to alcohol. And people were also 12 times more likely to attempt suicide if they'd got 4 ACEs compared with people who had none. 20 odd years later, in 2015, my maths is not the best, but anyway, Bellis and colleagues did this study of the English population underneath that one. And they found similar things, that there was this association between adversity exposure and health harming behaviours. So people with 4 ACEs compared to people who had none were twice as likely to be binge drinkers, 3 times more likely to be smokers, and 11 times more likely to use crack or heroin and go to prison. So these are huge increases in risk, aren't they? They're much bigger than the increases in risk we associate with genetics, for things like mental health problems and stuff like that. This study is very recent, the one on the right-hand side. It's a prospective study of 8,200 adolescents. They followed them up 12 to 14 years later, and they found that anybody with any exposure to one of the experiences on that list of 10 ACEs meant that they were 4.3 times more likely to develop a substance use addiction compared to their peers who didn't have exposure to ACEs. They also found, and this was a prospective study obviously, they found a gender difference. So men were 6 times more likely to be addicted to drugs. 5 times more likely to be addicted to drugs, and women were I'll say that again. Women were 6 times more likely to be addicted to alcohol, and men were 5 times more likely to be addicted to illicit drugs. So that's a very interesting study. Loads of evidence really in the realm of addiction. There's also loads of evidence in the realm of mental health issues as well. These are all meta-analysis, these studies. These are the best meta-analysis my colleague Filippo Veresi could find at the time. It's been updated since he originally did it in 2018. But he's a bit of an academic genius, so I trust his judgment. And when you look at these studies, it's really compelling. You see the same pattern, a dose-response relationship between exposure to childhood adversity and the likelihood of you developing any of those mental health issues. In some areas, we feel like we understand, or we're confident that we understand the causal mechanism, which in the case of psychosis, I can vouch for. But you still see this strong proportionate relationship between abuse exposure and the manifestation of mental health problems. I crossed out the word disorder, by the way, just because I think most of these manifestations of distress are understandable, make perfect sense in the context of people's lives. When you ask people what's happened to them, they'll tell you what's happened, and you go, yeah, it makes sense, you're depressed. You're paranoid? Yeah. Loads of people in your life have hurt you. I understand you're scared of people hurting you. Makes sense. I don't think that's madness. I think that's kind of self-protection. I think that's kind of social learning in action. So we're very good at pathologizing distress, understandable distress. We're very good at giving it labels and treating it medically, and we know that a biopsychosocial approach is usually more adequate when it comes to human distress. But if we look at the physical health consequences of trauma, which was less obvious to me as a psychologist, there's tons and tons of evidence. Psychoneuroimmunology is a whole branch of medicine, as I'm sure you know, and in America, for example, they're making this part of the curriculum for GPs and paediatricians. But this is a study of 2,500 people in Wales, and they compared people with adversity exposure, 4 ACEs, compared with people who had none. And it was in 2018. And they found that people with 4 ACEs compared to those who had none were twice as likely to be frequent attenders at the GP, 3 times more likely to go to A&E, and 3 times more likely to stay overnight in hospital in a 12-month period. They were also 4 times more likely to develop type 2 diabetes and 3 times more likely to develop heart disease and respiratory disease. Obviously, the last 2 are they're all exacerbated by lifestyle issues, but the last 2 are exacerbated by inflammation, which is caused by stress, which we're going to talk about a little bit more later. So it's not just mental health issues or addictions that are the consequence of being in pain as a result of childhood trauma. The body keeps the score, as Bessel van der Kolk said, and the body says no, as Gabor Mate said in his book. So Hans Selye said this ages ago, every stress leaves an indelible scar, and the organism pays for its survival after every stressful situation by becoming a little older, which is a bit depressing, isn't it? But if we've got buffering resources, if we've got enough on this side, we can deal with stress. We can deal with tolerable stress. The problem is chronic dysregulation of the HPA axis. So the stress apparatus, as you know, are called the HPA axis, the hypothalamic pituitary adrenal axis. And when that becomes activated for a little bit, that can be healthy, it can be useful, it's great for children growing up and developing, their brains becoming optimal. When it's tolerable, it means that it's a brief, prolonged activation. It lasts for a little bit longer, a little bit more severe, but we cope with it. Like coming here today and sitting in traffic for 2 hours, to go 18 miles. It's crazy. That was stressful, but it was tolerable because I had coping strategies. And I was sat in the car and it was fine and I was okay. So that's tolerable stress. But then it becomes toxic if it's overwhelming and it's prolonged and that activation happens day in, day out. We evolved the stress response to happen occasionally to save our lives, not to be triggered every day, day in, day out, hour after hour. Like if you're living in an abusive situation, or you're exposed to violence constantly or threat, or you're in a coercive relationship, or you're in a war zone, or you're a child living in a home where it's not safe. That becomes damaging. And the American Pediatric Association, in this paper in 2016, said, they summed up the evidence. It's a brilliant paper, I recommend it. Chronic dysregulation of the neuroendocrine immune system via the HPA axis has been documented to compromise every system in the body. Nervous system, immune system, cardiovascular, reproductive, and endocrine systems. Loads of evidence. It's very solid. It's been documented for about 30 years. We know the mechanisms. We just got to tackle the cause. This is the cost of, you can't read it, but I'll send you the reference. This is Karen Hughes and Mark Bellis from Public Health Wales, who studied the available evidence on the health costs associated with childhood adversity. And they calculated that the cost to England and Wales, just to healthcare, not social care, not policing, whatever, just health, £42.8 billion. Most of that is attributed to adverse childhood experiences contributing to mental health issues, contributing to addiction, contributing to violence, contributing to cancer and heart disease, and mental health conditions more broadly. Inflammatory conditions, type 2 diabetes. Again, we know enough about this now to say we've got to find a more proactive solution. We can't just pick up the pieces. Picking up the pieces isn't working. It's not working for patients and clients. It's not working for staff either, is it? Because everyone's exhausted and everyone's doing 2 people's jobs. And in big organisations, they spend all the time trying to get people back off sick or to recruit constantly because there's a huge deficit in the workforce in the NHS and social care. It's one of the biggest risks. So we can't keep treating the symptoms and ignoring the cause, I think is the top message. And when we look at people's use of drugs, alcohol, gambling, sex, smoking, porn, whatever it is, it's a self-soothing attempt. It's an attempt to feel better. And when you're in pain, you keep looking for painkillers. You know, it's as simple as that. So Gabor Mate says, who I have a love-hate relationship with as well, he always says, don't ask why the addiction, ask why the pain. And I agree with him on that. I think that makes a lot of sense. So they're all attempts to find relief. These attempts to relief are temporary. They don't work, but we keep craving them. We keep trying to find that relief, that ease from pain, from that disease. Often these attempts are harmful. Often they have impact on families. They're intergenerational. Often they affect you, your family, your children, and then it becomes this vicious cycle. I'm sure you see it. But what we know is treating the symptoms alone isn't a solution most of the time. The best drug treatment service in the country has a 10% success rate of getting somebody off opiates altogether. So that's, you know, by any measure, is not ideal. Services are not commissioned to do the therapeutic work a lot of the time. They're commissioned to do the harm reduction work. You know better than me, you're the experts on this, but the comprehensive psychotherapy work, the group work to address adverse child experiences, isn't that common in my experience. So what we see is that we attempt to help people be safer, we attempt to help them do less of the harmful behaviour, but very little of our resources is spent on giving people safer and better coping strategies, dealing with the underlying pain. That's the problem. Bariatric surgery is a great example, I think. Eventually we run out of ideas, we give people bariatric surgery, they lose weight, their health improves in lots of ways. But then we look at the long-term outcomes for people with bariatric surgery. They have 4 times the rate of other kinds of addiction because we've taken away food. And they find another way of self-soothing, which might be drugs or alcohol or gambling or whatever it is. They've also got higher rates of suicide than the general population and higher rates of mental health distress. So that doesn't work. We do the same thing with prison. We treat the symptoms and ignore the cause. Prison doesn't work as a solution. It's got to be rehabilitative for it to be a solution, but it currently isn't. I could go on, but I won't. I ain't got time. So you get the idea. One of the things I think we can do, though, is we can help people make sense of their pain. We can help them understand the distress that they're in and this comfort that they're seeking. And by the way, I love that Gabor Mate said, he interviewed a lot of people who used heroin, and he said, what does it feel like using heroin? And they're like, it feels like being surrounded by love. And he's like, well, why, if you've had an adverse childhood, a traumatic childhood, and you've not had a loving environment, why wouldn't you seek and crave that? And we're punishing people for that. We stigmatise people for that. But let's find them other ways of feeling loved and cared for. Let's find other ways of them feeling comforted, being able to regulate their nervous system in a way that they've not learned how to do. So if we can help people link the past trauma to their current pain and the way they're attempting to cope with that pain, maybe that's a catalyst for change. I've seen it in my own practice. I've seen that catalyst for change. It doesn't change overnight. But once you start to see things differently, you can take a different path. So I think that's part of the solution. I think part of the solution is talking to people about the source of their pain. I think, why are you in pain? What happened to you? What were your experiences in childhood? What trauma have you been through? And we're going to talk more about that. So this concept of trauma-informed care was coined by 2 mental health social workers in Buffalo, New York in 2001. They published this book, Using Trauma Theory to Design Service Systems. They were basically having the same ideas that some of me, myself and some of my colleagues in Manchester are having around the same time, which was everybody we see is affected by trauma, but we're working in a psychiatric system that uses drugs to treat them, and it doesn't work. The trauma's not resolved by medication. There isn't a drug to treat trauma. So how can we work in this psychiatric system that medicalises human distress and doesn't acknowledge the bad things that are happening to people? So that was the kind of basic message of the book. Let's design services to better meet the needs of people affected by trauma. So they talked about that. No one read it, of course. I published a book in 2006 on the links between trauma and psychosis. Very controversial. I'll bore you with some stories about that at the break time if you're interested. But the bottom line is it took a while. 2014, the Substance Abuse and Mental Health Services Administration of America, one of their public bodies, said, do you know what? Most of the people we work with in mental health services and addiction are affected by trauma. Maybe we need to take that into account in our policies, our procedures, our practices. Maybe we need to train our professionals to understand it. Maybe we need to recognise how widespread it is. Maybe we need to see that actually, do you know what? Maybe medicalising treatment isn't necessarily the only way forward for some people. Actually, there are lots of ways of recovering. This side of the scales provides lots of opportunities. So that's what they say, the 4 R's. Realising how widespread it is, recognising the signs and symptoms in staff, service users, people involved in the system, not just patients, but us as well, because we become traumatised by the work that we do, and life. Responding by integrating that knowledge into everything we do, and then not re-traumatising people. I worked in mental health services for 25 years. We're really good at it. We're really good at re-traumatising people. Lots of professions are, lots of sectors are, inadvertently. It's not that we're bad people, but our systems sometimes force us into poor choices, poor decisions, poor options, lack of options, actually. So I think there are 4 pillars to trauma-informed care. One is this ethos thing. It's about recognising people who've been disempowered, so trying to empower them, realising that people are low in social rank often and don't feel they've got any voice. We need to empower them, listen to them, give them choices, being sensitive to needs of spirituality, gender, history, being collaborative, being respectful, and fundamentally helping people feel safe. Because if you don't feel safe, your stress response is activated, your prefrontal cortex switches off, you're in survival mode, you can't relate, you can't learn, you can't develop, you can't grow, you can't make use of therapy or whatever it is you're doing. You can't hear what the GP is saying to you. Trauma-focused therapies, we need to sort that out. People need access. Return on investment is very good. They'll stop bothering you if they get the right help. People are not getting that help. That's not acceptable in my opinion. And also we need to promote resilience across the life course. So we're making a start with things like social prescribing, I think that's good. Organisations like Sport England and the local versions of that, helping people get involved with activity. There's good evidence for that as well. Social support is a really powerful part of people's recovery. I think we need to focus on some of those social assets. But then the other thing is we need to ask people what's happened to them. Because we know if you don't ask people, they don't tell you. And if they don't tell you, they're going to get the wrong help. So I work with people in mental health services for nearly 30 years, and so many times people would say to me, how come you're the first person to ask me what I've been through? I've been in mental health services for 25 years, I've been on every drug you can mention, I've had ECT, I've been in hospital so many times. How much does that cost? None of it helped. You're the first person to ask me what happened to me. That is not an unusual experience. I've got loads of those stories. And there's a lot of research that backs that up. If you don't ask, people tend not to tell. The one on the right is a research paper that was produced by University of Sussex and a charity called Survivors in Transition. They looked at 608 abuse survivors, and I provided with them secretly some clinical case material from people I work with. And when I was seconded to Department of Health, I shouldn't have said that on camera, we can edit that out, right? We worked with an economist and we kind of calculated how much it cost. If people didn't get the opportunity to disclose, and they got the wrong treatment for many years, how much that cost? So we did that kind of calculation. And in this study, they found that on average for those 608 people, from the point they started being abused to the point where they were able to tell a professional and be heard and have it recorded, was 27.5 years. Which is crazy, because for that 27.5 years, they're getting the help that isn't optimal or focused on what they need. And the cost per survivor was £4.9 million when we looked at their detailed case records. So age 11, go to CAMS, self-harming, suicidal, no one asked them what happened to them. Instead, we treat the symptoms and it carries on, and it bounces around the system. Loads of examples in that paper of that. And the cost for that 608 people was £3 billion for 608 people, because they weren't getting the right help. So, another study, really important one, John Reid and Alan Fraser, 1988, Auckland, New Zealand, psychiatric unit. They observed 100 admissions. 8% of people, at standard practice, disclosed childhood abuse of some sort. Voluntarily, 8% of people, standard practice. They then asked the next 100 people directly, have you ever experienced physical, sexual, or emotional abuse at any point in your life? 82% of people said yes, thank you for asking. Because they kind of expect when you're in a situation where you're asking for help, that someone asks you questions about yourself. 82% versus 8%. It's pretty obvious what we need to do. But professionals worry about asking these questions because we worry about making it worse, putting our foot in it, destabilising someone who's already struggling. We have realistic anxieties and concerns. What we know is you give professionals a little bit of training, a bit of confidence, you see that actually the worst that you imagine doesn't happen, that people actually appreciate it and open up to you, changes everything. So, Fleet Inanda, who did that original ACE study, in 2014 did an observational study of 135,000 people. These were people coming into the Kaiser Health insurance program in San Diego, California. And they were all given an ACE questionnaire as part of their health assessment. So they did lots of tests, lots of assessments. One of them was an ACE questionnaire. They then got to go and speak to a doctor or a nurse about their adversity in the context of their health. They followed them up for a year. In the following year, that 135,000 people used 35% less visits to their GP and 11% less visits to the emergency room. There was no therapy program. They got the chance to talk about what happened to them for the first time for most people, to be heard, to be listened to be validated. And Vincent Veliti said, slowly, we came to see the asking, initially by an inert mechanism, which was this piece of paper with a questionnaire on it, but followed up by a human being in the exam room, coupled with listening and implicitly accepting that individual who's just shared his or her darkest secrets, is a powerful form of doing. So it's a therapeutic act, isn't it? It's an act of confession, it's an act of trust, it's an act of unburdening. There's a huge amount of evidence that that's beneficial. And it's a catalyst for change. Because you get to say to that person, thank you, I believe you. Thank you for trusting me with that. I really appreciate your bravery. Thank you. I believe what you told me. That must have been really difficult. Is it still happening to you? If not, does what happened to you still bother you? Does it still cause you pain? That's a really important conversation. And then you can give people the kind of help they want. You can also say to people, if you're lucky and the opportunity arises, what happened to you happened to you. You didn't make it happen. It wasn't your fault. So one of the key targets in cognitive therapy for trauma is self-blame and shame. And if we can relieve that by saying, it wasn't your fault, you were a child, you were powerless, you couldn't have done anything differently. That's a huge unburdening. It's a weight released, it's shame released, it's self-blame released. So it's a really powerful opportunity. You don't have to be a psychological therapist to have a therapeutic impact. You know that. It's kind of what you do every day. But this is a golden opportunity. And people say, oh, well, what if people want psychotherapy or CBT referrals? The waiting lists are really big. Our evidence and Felicia's evidence is it does quite the opposite. It doesn't lead to increased service utilisation. It leads to reduced service utilisation because people get what they need and they start making sense of things. Most people might come back to you and go, oh, yeah, I'd like a conversation. I'd like to follow that up and make sense of it. But they don't want to be referred on, actually, because people say, look, I've trusted you. I've told you. I don't want you to refer me to somebody else. I want to just try and make sense of what happened. So a very tiny percentage of people go on and say, right, I need CBT or EMDR. Most people want to talk to you because they've trusted you. We've done this with lots of GPs, right? So we've done this in Lancashire in this multi-centre trial funded by NHS England back in 2018. We've done a trial for Scottish Government in the deep end practices. Paper was never published because of COVID. Story of my life, but anyway. We've also done a trial in North Macedonia funded by UNICEF, which is successful. Well, I mean, again, we haven't published the paper because of COVID, but you know, I can give you more information and details if you're interested. But we've done this lots of times with GPs, and we've shown that it's feasible. We can make it work in 15, 20 minutes with good planning, but we can also be confident that it's acceptable to patients. So I can send you the details. We haven't got a lot of time, but patients who took part, I think there was like 200 and odd people took part in the inquiry in this trial. 123 completed the follow-up questionnaire, and 94% of people said, yeah, it was clear and understandable. 86% of people said GP surgery is the right place to be asked these questions. 84% thought it was important for health professionals to understand what happened in their childhood. And 70% said their appointment was improved because they'd been able to talk about what happened to them to their GP or practice nurse. And 87% agreed it was providing that information to health professionals acceptable. So approval ratings pretty high actually, aren't they, really? For most things we can't get people. If we give everybody a fiver, we'd probably see less approval ratings than that because someone always disagrees, don't they? So the conclusion of this study from the people who did the evaluation was Public Health Wales. High prevalence of both physical and mental health problems among general practice patients with ACEs highlights a clear need to respond to the wider determinants of health and examine a more trauma-informed approach to primary care. And as you can see from those statistics, people with more than 2 ACEs had 2.5 times the rate of asthma, 3 times the rate of multiple chronic health conditions, and 3.5 times the rate of mental health problems. And for over 2/3, they'd never been asked before by a professional what had happened to them. We deliver training to lots of different kinds of organisations to increase confidence for practitioners. There have been 7 academic evaluations, 8, probably 9 now actually, independently evaluated the programme. These are the collected findings. Training increases confidence, which means it's more likely to happen. Inquiry is acceptable to service users and feasible in a whole range of different settings with planning. It means people get the right help, and it means they get the right help sooner. And it also means that people demonstrate increased motivation to make positive changes. We see that a lot. And if you ask these questions to parents, they think about their own experience of growing up. And they go, oh my God, I'm just repeating what my parents did to me. And my childhood wasn't very good. Maybe I do need some help, actually. Maybe I will have some help, because I want better for my kids than what I had. So there are lots of benefits here, primary, secondary prevention, but also in terms of giving people the right help sooner. And it also leads to a conversation about resilience. So we talk about what happened to you, but we also then talk about what can we do? What help do you need? So it leads naturally to this conversation. And this is an image from California, where the whole state of California, GPs and paediatricians, are involved in a screening program for ACEs, Public Health Initiative. So they all get a payment like you do for health checks and flu jabs and what have you. They're incentivized to do it. They've got some, the government's legislation in California. This is what happens. Paediatricians, GPs do this. And then they have a brief intervention conversation going, okay, these are all the things that we know help people cope with stress. Social support, number one. What's your social support like? Let's look at options. Quality sleep, nutrition, physical activity, probably a bit better known, but lots of people don't know about that either. Mindfulness, yoga, access to nature, all things that reduce stress hormones and help us cope better with stress. And have positive physical consequences as well. And then we talk, obviously they talk about healthcare, mental health care. So this is not a treatment approach necessarily, it's a public health approach. Conclusions. Adverse child experiences cost £42.8 billion a year to the NHS in England and Wales. So having a greater biopsychosocial focus that involves understanding people's experience of trauma, if that's contributing to their problems, we probably need to know more about that. We probably need to be more comfortable talking about that. Routine or targeted inquiry, in my view, and as has been shown in lots of studies, most of them in the US, but there are some here, means people can get the right help sooner, instead of getting the wrong help, ineffective help, or even harmful interventions for 20 odd years. It's a normal conversation now, isn't it, to ask people about suicide. If you see someone who's depressed, you'll say, you're having suicidal thoughts. Do you feel hopeless? Have you got plans, etc.? That's a normal conversation. When I started training, it wasn't. We were encouraged not to do that, actually. Midwives and health visitors ask about domestic abuse, quite rightly so. Why is this not a normal conversation for us to ask with people when we know that their conditions are probably affected by this? Routine inquiry will certainly our approach is feasible and acceptable in primary care and lots of other settings. And as Felitti said, this act of listening, accepting, and asking people is a powerful form of doing. Because treating the symptoms and ignoring the cause isn't working. And to quote Desmond Tutu, there comes a point where we have to just stop pulling people out of the river. We have to move upstream and find out why they're falling in. Thank you.
Thank you, Warren. Fantastic. So, I'd like to open up the floor for any questions for Warren. Yep, gentleman over there. Just wait for the microphone, friend.
Is it working? It's not working. Is there a switch on front? Oh, it's working now.
There you go. Who did you have asking the initial question?
Oh, with the GP trial?
Yeah.
So, at a standard appointment, they would provide some information and say, we're going to start asking all of our patients about their experiences in childhood because we know they can have an impact on health and well-being and all these other things. Is that something you'd be interested in? If people said, yeah, I'm open to that, they gave them a bit of information. The next appointment, they would be given a questionnaire in an envelope. They'd fill it in, they'd take it in to see the nurse or the GP, and then they would have the conversation. So it's all about setup, really. The actual appointment didn't take much longer, but obviously if you're seeing people frequently and not resolving the problems, that little bit of extra time is an investment in further, better outcomes and better relationships, I think.
I'll take a question online and then over to you, sir.
Oh, yeah?
We've got a question here from Nicholas Swift, who is asking if we ask these questions as a matter of routine around ACEs, patients may feel we're not really interested and these things are deep and painful, so we may get false responses. Is there a risk of that?
I think when we use the term routine, I don't mean it like we just throw it into the conversation like, so yeah, how much do you smoke? Yeah, how much do you drink? How's your mood? Have you ever been abused? That is not what we're talking about. There's a 4-stage model that we teach, which is about, let's revisit confidentiality. Let's revisit the rationale for having this conversation. Let's then do it in a sensitive way that makes sense to people. And then let's respond in a therapeutic and compassionate fashion that is a catalyst for change. And we know how that looks, and we know what works, and people tell us what works. So I don't think there's any risk at all of people feeling that we're not taking it seriously. I think what survivors tell us already is they've often tried multiple times to tell a professional, and a professional says, oh, I'm sorry, I think you need to speak to our psychotherapist. It's not for me. This is not my area of specialism. Or, actually, we've kind of run out of time, so I think you probably need to speak to your key worker next week about this. It sounds ridiculous, but it's so common. You look at the studies and people say they've tried multiple times. So I think we make it routine in the sense of all new patients who come to our practice, we ask them a load of things about their health. One of the things we ask them is about adverse child experiences, and we do it in this way. Or people with chronic multiple health conditions, people who've got addictions, people who are in pain, people who've got particular mental health conditions. There's a rationale for asking these questions. It makes sense. And as long as it makes sense to people, they tend to appreciate being asked. Not think, why are you asking me that? Because it makes perfect sense.
Yeah, great, thank you. Gentleman here.
Thank you very much for that. Jim O'Toole, I work in addiction in Wales, North Wales. But that was a very good session. Each time I come to a conference, there's usually one outstanding session. It's early days, but this could be it.
Wow, thank you.
So,
I thought you were going to say, well, I've not been to it yet, but I'm a hopeful.
No, what I was saying is I realised, I worked in addiction for many years. I'm not a psychiatrist, I'm a GP by background, but then I work full-time now in addiction. And it dawned on me gradually the link between addiction and trauma, adverse childhood experiences. And, it's just undeniable. It's just virtually everybody you see. And although I'm not a psychiatrist, quite often people come in and I ask them about their history. They tell me they've been diagnosed as borderline personality disorder or emotionally unstable personality disorder, as they call it now. And I will say to them, I don't think you have got a personality disorder. It's the trauma, it's what happened to you. And they're really relieved.
Yeah, yeah, completely.
Yeah.
I'm totally with you. I always joke with people, I can cure paranoia in about 10 minutes. Psychiatry have been trying to do this for 100 years. It only takes about 10 minutes because what you do is you go, okay, so what happened to you? And people go, well, people hurt me a lot. And you go, okay, and so what are you concerned about? Well, I'm scared that people are going to hurt me. Okay, that makes sense. I think we call that hypervigilance to threat, right? Because people have hurt you, therefore, this brain that we've got says, let's look out for danger so people don't hurt us again. That's not madness, that's survival. So it's how it's framed, I think. We can either pathologise it or we can normalise it. We can either approach it with compassion and humanity or we can try and put a label on it and treat it. And I think that's part of the issue. We've got to have this biopsychosocial perspective on human distress. And we're all trained in the ways that we're trained, that's the other thing. And I think for me, it took me a long time to step back from my particular niche and see that actually the solution is prevention, helping families in the early years to raise their kids in a healthy way, surrounded by love and support. That's the solution, because a lot of these things are preventable. So, yeah, I'm totally with you.
Thank you.
Thank you.
Great. Got a chance for one more question. Just at the gentleman at the front, please.
Hi, Graham Dixon. I was really interested in what you said. I've done a lot of projects around sort of public health, making every contact count, and these sort of early intervention programs around drugs and alcohol misuse. And the one thing that struck me, you mentioned Kaiser Health. They did a really interesting program where they used care coordinators to do long assessments with patients routinely and do a care plan. Do you think there's space for us to sort of combine this structurally so that instead of us waiting, we can start actually reaching out, and this is part of a structured approach to patients?
Completely. So when I say routine, what I mean is there are a lot of things we do routinely in practice. It's part of our workflow. This should be one of them. We get a new patient, this should be one of the questions we ask. We get a patient that's struggling and they've got chronic problems, they're not getting resolved, this should be something we ask. People with mental health issues, we know that these experiences predict and increase the likelihood of mental health problems. None of this is a surprise to us, so therefore why are we not asking these questions? It's like there's a part of our assessment we don't like much, so we're not going to ask. It's not our thing. We don't want to go there. It's a bit, we have an away response from it. And I'm not criticising anyone, but I think if we can improve people's confidence in those questions, it would become standard, like, are you suicidal? Do you feel hopeless? It's...
So exactly the same.
Completely.
Social workers didn't want to damage the relationship. Social workers didn't want to damage the relationship by asking difficult questions. And then if you can't do that, you really have to question, is there a relationship?
Yeah, totally. So there's two things. Like, one is the training. So we were asked by our health visitor with our first child. I've got to ask you this question. You're a nice family. I'll tell you what, we'll just skip it. Well, no, what's the question? Is there any domestic abuse? And I'm sat next to my wife going, who is she asking? And should I be here while we're asking this question? That'll be the health visitor. That's my doorbell, actually, sorry. So it's not that we don't understand it's important. I think sometimes we just don't have the confidence and we don't know how to do it or when to do it. And I think if we give people some basic training, we plan it into our workflow, it's just what we do. So they're very effective, these doorbells, by the way. Even if you put it on airplane mode, they still manage to find you. Have we got time for one more?
We'll squeeze in that last question there, but I'll have to be quick, I'm afraid.
Hello, my name is Pat Rose. I'm a substance misuse worker from Bristol, as you can tell by my accent, maybe. We've talked about some adverse childhood experiences a lot, but what we never include is racial trauma. And I wonder what the barrier is around that, because my wish would be that becomes normalised in the same way.
Yeah.
If you think about our changing demographics in the UK, it's really important.
Yeah.
And also if you think about the poor outcomes for the Black, Asian, minority ethnic groups in terms of health, education, economically, etc.
Yeah.
But it never gets mentioned.
I think that's a really important point, and it's another one of those areas that we don't want to get it wrong. We don't want to put our foot in it. We don't want to err into territory. We don't feel confident or legitimate. I had this issue. I did some work in Birmingham and Solihull recently, in mental health services, delivering routine inquiry training, and I asked to meet the experts by experience group, which is a very diverse group of people, and I said, I want to talk about racial trauma as a part of the training, but I kind of don't know how to approach it. I don't know, you might have noticed, I'm a white, middle-aged, privileged man. How do I do this in an effective way? And they were like, just say what you just said and then get stuck in. But don't avoid it. Don't avoid it, and don't palm it off to somebody else from that community who can talk about it because you feel uncomfortable. So I think the key thing is to, become a practitioner of talking about these things and addressing these things rather than an observer with this fear that you're going to get it wrong. So, yeah, and I think that's one of the areas that this field of trauma and resilience-informed practice will start to embrace a bit more. We're going to have to, acknowledge intersectionality, which I think fits really well with the power threat meaning framework. So we probably don't have time to go into it, but if you've got a moment, look up power threat meaning framework, which is a beautiful alternative to psychiatric diagnosis and fits beautifully with the concept of intersectionality as well. It's not that complicated, but I think we haven't got time to get into it. But there's some great resources online as well. And British Psychological Society have a page on it. PTMF, Power Threat Meaning Framework.
Brilliant. Warren, fantastic.
Thank you so
I'm sure
much.
we should have listened to you all afternoon. It's fantastic.
Well,
Thank you
I'm very
much.
grateful. Thank you for coming.
Warren.